So I'm Dr. Tim Pehl. I'm a family physician. I've been here in town since 2001. Love it here and don't intend to ever go anywhere else, so let's get started. As I was thinking about this talk, you know, it could have been easy just to come up with a list. If you have this, go to the ER. If you have this, go to... But not everything we see easily falls into lists. So I thought it'd be a little bit more helpful to kind of explain what you might expect if you go to the emergency room versus if you go to our rapid clinic versus if you go to the clinic. And you know, I've had several, through the years, several encounters where patients have come up to me and said, you know, I went to the ER and all they told me is I didn't have a heart attack. But they didn't tell me why I had chest pain. And it's like, yeah, that's kind of what they do. You know, they're going to make sure you're not going to die in the next 24 hours, and then they're going to send you to us in the clinic, and we'll try to sort out maybe why you had chest pain. So at Grand Itasca, we have three primary points of entry, three different places that you can receive your initial care. Emergency department. About 5 years ago, we started the rapid clinic, and of course, we have the primary clinic, and that's been around for a long time. I hope to, by the end of the talk, help you understand what type of care you would receive at each one of these places, and help you make decisions in the future as to where those three would be the best place to receive the care. And then also help you understand what to expect when you actually show up there. So the rapid clinic is an after-hours clinic. They actually open at 10 o'clock in the morning, and they stay open till 8 o'clock at night, 7 days a week, closed for a few holidays. If you go to the rapid clinic, it's literally an extension of our regular clinic. It's staffed primarily with nurse practitioners, but you know, when you get the bill after you've been there, it will be a clinic-based bill. So that's a big thing nowadays with higher copays, and you know, generally speaking, when you go to the ER, you have a much higher copay. The rapid clinic is still part of our clinic. In general, you know, they do a good job with kind of one set of problems, generally some of the more simple problems. Poison ivy this time of the year is really common. Simple rashes, shingles kind of rashes, colds, mild pneumonias. They do not generally treat chronic problems. So if you have high blood pressure and it's 6 o'clock and you want to talk to somebody about your high blood pressure, that's probably not the best place to go. If you go in for something else and they see that you have high blood pressure, they're going to say something about that. They might, if it's extremely high, they might do some testing. They might initially start you on some medications, but they're going to generally send you back to your primary doctor. The age limits, you have to be at least 6 months of age, and I don't think anyone here has an issue with that. Beyond that, there's no upper limit. Some of that is actually, so children under 6 months of age are at really high risk of a little bit more unusual things. And if they're sick, they can be extremely sick. We'll get to that when we get to the ER talk. So we do give our rapid clinic providers a few days off. They get 4 days off a year. They've been extremely busy, and I want to, you know, send out some appreciation to all the work they've done. So this summer has been the busiest that we've ever seen the rapid clinic be. The emergency department is for, in general, critical problems. Now, it can be hard to know if the problem you have is a critical problem until you actually talk to us, but if you think that something you have is going to maybe result in you needing to be in the hospital, or if it's something that you're extremely worried about, if your wife is telling you to go there, you probably should go there. So the people that are at the highest risk of having severe health problems are people that are at the extremes of age. So newborn babies, you know, a newborn baby with a fever, that could be a really big deal. You know, that baby might have a brain infection or might have something that's life-threatening. The same is at the other end of the spectrum. You know, if you're over 80 years old and you've got a fever and it's 101, that can be a really big deal too. So that could be a life-threatening pneumonia, for instance. That's one of the leading causes of hospitalization in the elderly, and actually one of the leading causes of death in the elderly. If you have a history of heart conditions, you know, if you take a handful of pills, if you've had a heart attack and you're having chest pain, by all means you should go to the emergency room. That's one where a lot of times people will call, you know, they talk to the nurse, and on the phone they're trying to convince my nurse that they're not having a heart attack, and maybe they're not, but maybe they are. If you call our clinic and you say, I'm having chest pain, our nurses are going to assume the worst to begin with, and they'll try to shunt you over to the emergency room. We get a fair number of complaints over that because people say, no, I just want to see my doctor. And we kind of have to assume the worst. You know, we really don't want you to be having your heart attack in our lobby. We don't have the resources in the lobby to appropriately treat you for a heart attack. But also, I've seen things go the other way too. You know, again, I'm going to pick on men because I can get away with that. But men often will ignore their symptoms, and you know, they'll come in with 3 days worth of chest pain, and it's their heart attack, and you know, they sort of fall out of the car onto the floor of the emergency room. That's not good either. You know, we want you to get timely care, and we want to do it in a reasonable amount of time. And there's a lot of heart disease. You know, that's the leading cause of death in our country, and we definitely want you in the emergency room if that's what's going on. Strokes, if you think you're having a stroke, especially early on, so there are some protocols in the emergency department. If you are only an hour or two into your stroke, get into the emergency room, because there are some scenarios where we can give you the clot busting medications, and sometimes we can reverse that stroke. Not very often, you know, so sometimes people show up and say, okay, you know, give me my medicine. There are some really strict guidelines on who gets that and who doesn't, but it's actually worthwhile coming in. And that's definitely something that you should go to the emergency room for. If you've had loss of consciousness, you know, really short of anything other than too many beers, you really should go to the emergency room for that too, because a lot of times that's actually heart-related stuff. That's not something that we're well equipped for, certainly not in the rapid clinic. And sometimes we'll see people in regular clinic who, you know, maybe 2 days ago had a spell where they passed out and they're not sure what's going on. But the emergency department is the best place for most broken bones. In the rapid clinic, you know, we can handle, hey, maybe I think I broke a bone, but you know, if you fall out of your tree house and your arm is bent at 90 degrees, you should go into the emergency room. And certainly if there's any bone sticking through the skin, go to the emergency room right away. And then most open wounds too, we have you go to the emergency room. Sometimes people will show up at the rapid clinic and get shunted over to the emergency room too. And I understand, you know, my daughter just broke her arm 6 weeks ago. I just got the bill, and I was astounded at how much it costs, you know. And I get it. We have a much higher copay when you go to the emergency room. It's over $1,000, and rapid clinic would have been a $50 copay. But her arm was bent, and you know, she needed to get it set, and that was the right place to go. The rapid clinic does not do work comp either, if that's an issue. So if you come to the rapid clinic with a work-related injury, they're going to have you go over to the emergency room. If you're in an ambulance, they will only take you to the emergency room. So we have, in the emergency room, we have 24 hours a day, 7 days a week. We do not give the emergency room docs holidays off. There's always at least one doctor down there. Most of the time there are 2 doctors. We do have some nurse practitioners and some physician assistants as well, but we always have one doctor down there. In the emergency department, you will always encounter a triage system. So sometimes, you know, I'll see people in the clinic on a Monday or a Tuesday, and they'll say, boy, I went to the ER with a sore throat and I waited for 5 hours. I shouldn't have had to wait for 5 hours. I only had a sore throat. And I tell them, congratulations. They determined that you did not have anything that was immediately life-threatening, so you waited. And other people might have come in and they might have been seen in front of you, but you get questioned right at the front end. You get questioned by a nurse, and the nurse, based on some protocols, will determine, you know, are you having chest pain? Are you at high risk of having a heart attack? It's also really important when you're talking to us and you're talking to emergency room docs or anybody really in the rapid clinic to accurately represent what's going on. So there are times where people will underreport what they're feeling because they, you know, don't want to have a heart attack, for instance. And it's really important that we know, what's going on, and that everybody that's asking the questions really does care about what's going on. You're going to get asked the same story about 10 times. So by the time when the doc gets in the room, you're going to be sick of telling your story. But everybody along the way is doing something with all the information that they're getting, and they're trying to figure out how much help you need, how quickly you need the help, and what more needs to be done. So the triage system, it's actually military-based, and the idea is to get people that need immediate care that can be helped immediately, that are in life and death situations, to get that care as quickly as possible. So certainly if you have a cold or a sore throat, you might wait. And I'll tell you, when I look at national averages for waits in emergency rooms on Sunday evenings, 5 hours is phenomenal. And ours are well below 5 hours. It's pretty rare that you have to wait that long in our emergency room. So the question is, are we having doctors that are working from other places coming in on the weekends? And that is true. So we've had, in the last year or so, we've had some illnesses and whatnot. And in order to keep the emergency room staffed, to the level that's required, the 24 hours a day, we have some docs that are contracted that will come in. And so it may not be, if you go there often, it may not be a face that they're used to, but and that's becoming a reality of rural medicine across the board. Same in our hospital, and we're starting to look at maybe needing that in the clinic now as well. But with all the baby boomers are retiring, so a lot of baby boomer doctors are retiring too, and that leaves my generation to take care of the remainder of the people, and there are only so many of us to go around. That's partly why I'm here, so that we can help people, get the care in a timely fashion, but also in the appropriate place. So the emergency room, also medication refills, they understand your prescription is supposed to come in the mail and it didn't show up, and your high blood pressure meds are going to run out on Sunday and it's Saturday. Really, that would be something that ideally, if you can get in while the rapid clinic is still open, they would give you enough meds to bridge you. But there are scenarios where things happen, and you accidentally drop your high blood pressure pills on your supper and you can't wash them off. I don't know. But if you go in and it's a chronic disease or it's a chronic medication, they're not going to give you your supply, because they want me to take care of it. They want me to do the changes in the dosing, and they want me to say, yeah, this is the right medicine for you. They might only give you, 3 pills or 5 pills. So you might have just spent $1,000 to get 5 pills. Most of the time, plan ahead, because that's going to be pretty expensive, and then people are generally frustrated. Where would somebody go for tick bites? We are working on a protocol where you just call in, and our registered nurses would be able to do a lot of that over the phone without having to see anybody. It's based on, the guidelines have to be based on pretty strict scientific criteria. So it has to be, it has to be a deer tick, not a wood tick. It has to have been attached for 24 hours. And if you have no other signs of Lyme disease, for instance, then you would get the 2 doses of the antibiotic, and then with close follow-up if you go on to develop Lyme disease. That's been shown to prevent Lyme disease about 80% of the time. If you have a tick that's embedded and you can't get it out, and you want us to get it out, that would be appropriate to come to either rapid clinic or come to the regular clinic. If you have signs of Lyme disease, usually that kind of builds slowly, so that's usually something that you can be seen, you wouldn't necessarily have to go to the emergency room for. But there's another tick infection called anaplasma or ehrlichiosis, and I have never put anybody in the hospital for Lyme disease, but every summer I usually have 1 or 2 of my patients that ends up hospitalized for anaplasma or ehrlichiosis. So with that infection, again, that's a deer tick bite, so they're so tiny you often don't know it, but you do get high fevers, and that can stop your body from making white blood cells. So people generally look really sick. They look like they have a really bad flu, and they come in and they think they just have influenza, and we do the testing, we say, no, I'm sorry, we think that you have this tick infection, you have to go into the hospital. a whole lot of this is kind of the big picture. You know, there isn't like one thing that says, boy, I should go to the ER unless you are at risk for having a heart attack. But it's kind of the whole clinical picture. What else is going on and what else is happening here. And in the emergency room, you know, you may be seen right away, and you may, you know, if we take care of everybody, so if somebody has a car accident and all of a sudden 6 people were injured and they come in, they may have to make some decisions where you might wait in the waiting room or in your exam room for a while. But we don't like to make people wait, but at the same time we want to give everybody their due attention, and we really don't want you to have to go back to the emergency room. You're welcome to do that, but our hope is that you wouldn't have to go back after. So I'm a primary care provider. I'm a family medicine physician, so I'm biased. But there is very, very clear data, clear information that if you can't name your primary care provider, you have worse health outcomes than people that can name one. And it can be a nurse practitioner, it can be a physician's assistant, it can be a doctor, but that is the best way to receive care. And there are just so many things that we can filter through for you. You know, we are the entry point for all of the healthcare. Everything from, you know, seeing the specialist to, there are scenarios where people come and you're in my clinic and I call the emergency room and say, hey, look, I got to get somebody down there right away. You know, every few months somebody I figure out has had a heart attack and we've got to get them down to the emergency room right away. We tackle complex long-term problems. You know, generally if you're in the emergency room or you're in the rapid clinic, it's really what's your one problem. You know, the ER mentality, the docs in the ER really want to keep you alive for 2 or 3 days. And then beyond that, it's up to us. So once they've ruled out the fact that your chest pain isn't a heart attack, they're going to send you to me, and I'm going to try to take into account all of the things that have been going on in your life. You know, everything from, you know, did you pull a muscle putting your doc in, to do you have a shingles rash on your chest? You see that every once in a while. And then on top of that, if you say, oh yeah, by the way, you know, what do you think of this tick that was in my leg yesterday? I can do that. And then I'll tell you though, the oh yeah, by the ways, if you can do those at the front end of the visit, that really helps us out a lot. Sometimes we get caught up talking about, you know, where the fish are biting or something, and then the time has passed, and then, but we do a lot of planning. Before you come in to see one of our providers, the night before, the nurses will pull the charts and do all kinds of, we call it chart scrubbing, and we really want to try to do as much as we can in that limited amount of time, and we want to get as many of your refills done, and we really do want to do it all. We can't always do it all in one visit, but that's our hope. Again, this is probably a plug more for what I'm biased against, but we really do try to take care of every facet of your health. You know, I often know if my patients are having marriage trouble, or if their kids are in legal trouble, or, you know, all kinds of things that are contributing to your overall health that the ER doc might not have time to really get into, or might, you know, it might not really be pertinent to what's causing that stroke. But from my angle, it's pertinent to what's helping you either live with or not live with in a healthy way the other health problems that are going on, you know. If everything's going on, everything in your life is really wonderful, a stroke might not be the end of the world. But on the other hand, if you've got a lot of other stuff going on, that could really be a pretty devastating event for you. So the question is, you know, how we're very short-staffed with physicians. You'll see we're hiring more nurse practitioners to try to help with some of that. In general, a lot of, you know, maybe a third or so of us now work in close conjunction with a nurse practitioner or a physician's assistant. But unfortunately, this is starting to be the reality in modern healthcare. People are living with many, many more complex long-term problems. You know, things where it used to take me 10 minutes to really get to the bottom of things, and I could see up to 30 people in a day. You know, I'm now seeing fewer than 20 people in a day, just because of how complex things are, And on top of that, Medicare and insurance companies are requiring a lot more out of us as well. So, when you come in, we're going to ask you, are you feeling depressed? Are you, and people kind of roll their eyes and say, I just saw you 2 days ago. Why are you asking me this again? But so a lot of these questions, I know they're annoying, but that one in particular, our county has a really high suicide rate, and there are things that people don't come, they don't come clean on the first time you ask, or the second, or the third time. And sometimes it's not till the nurse has kind of brought it up, and maybe they, I've had the same nurse for a long time, and maybe they feel comfortable sharing that with her. But it's not till I get in the room, and they still may not say, Doc, I really do think I'm depressed, or I'm thinking about hurting myself. They might say, why did you guys ask that question? Or we ask about safety a lot too, and that's another question. Well, what do you mean by that? Well, are you in danger of your house falling in on you, or are your children stealing your money from you? Because that happens a lot, and there's a lot of financial abuse of our elderly population, and so. Yeah, there are a lot of things that are going into the access problem. When you look at us compared to the rest of the country, we actually score very high in access, which means that the rest of the country scores really poorly. So I was talking to a colleague, well, maybe a year ago or so, from the Ohio area. And in Ohio, it was a 3-month wait to get in to see a primary care physician, but you could see a cardiologist in a week. So if you're having chest pain, what are you going to do? You got to see somebody. So you go to the cardiologist, and you pay the $1,000 copay, and they do their cardiology thing, and they say, well, it's not your heart. And then you're left, $1,000 short, and then 2 days later, you get the rash on the side of your chest, and it turns out to be shingles. What do you do? So our country has not trained enough primary care physicians, and that's just kind of the reality. But fortunately, we have a really strong group of primary care physicians. We have a really dedicated group, and we are recruiting as aggressively as we can. So if you guys know anybody, that's how we get some of the best people up here, is through networking. And if you know of somebody who's got a relative who's coming out of training, by all means send them up here, and we'll get them, and we'll show them what a great town it is, and what a great place it is to live. And we've got a beautiful facility, and we've got a lot going for us. But as a result of what you're saying, that's part of the reason why our rapid clinic is so much busier this summer. And then the same with the emergency room. And even if it's I would much rather see you, 5 times in the clinic versus you having to go to the emergency room once. Oh, that's a closely guarded secret. No, because what we do in the clinic, we warp time. This is serious. Part of my talk was going to be how doctors think. So I'm also an adjunct professor at the university, so I have the medical students. Anybody who's been seeing me for a long time, I often have a medical student with me. And there's a lot of research into what we do and how to make it more efficient, and how to, and there are things we can do that can make 20 minutes seem like I spent 45 minutes with you. There are things that we can do that can make 20 minutes seem like I spent 5 minutes with you, and leave you really dissatisfied and irritated. So that's a good question, because people call and say, well, I want to make an hour appointment, or I want to make a 15-minute appointment, or I want to make a 20-minute appointment, and you're not going to get a straight answer on that. What you should do on the front end, though, is be really upfront and honest about what you want that appointment to be about. So for the most part, we have short visits and we have long visits. And if you've got one problem, generally you're going to get a short visit. But if you say, I've got 5 or 6 things I want to talk about, then whoever's on the phone with you, or if you're doing it on a MyChart app appointment scheduling, go for the longer one. And our schedule is usually, if there's a question, they'll do a longer one, and then we can shorten it beforehand. Now, when you get in my office, how long does it take to tell somebody they've got cancer? Does that take 10 minutes? Does that take an hour? It depends. That's a tough one. I've had patients, it's been 10 minutes because they come in and say, yep, I knew it was going to be cancer, and they've already gone through all the processing, or maybe it's a recurrence of a cancer and they just knew. And then I've also had patients where I've spent an hour with them and they leave, and the next day their spouse calls and they have no idea what was said, you know, just because they can't emotionally process it. Because of that, you know, that 15-minute or maybe it was a 15-minute appointment for something they had no idea was going to be cancer, that might throw me an hour off, but I'm going to spend as much time as it takes, and I might, you know, come back and have you sit there for a while and come back over my lunch hour or whatever. But that also means that, you know, you might wait a little bit longer if you're scheduled for the 3 o'clock appointment. I might not quite get to you at 3 o'clock. We try to keep people informed as they're sitting in the waiting room, but we want to respect your time too. So I didn't answer your question, but short ones or long ones, that's probably the best way. Generations all behave differently. So this is kind of fascinating to me too. So depending on what generation you came from, you have different expectations of your physician. Interestingly enough, the pre-World War II generation, they have the highest satisfaction with their physicians, and they just are kind of, you know, they just sort of do what you tell them to do, you know. And if things don't work out, they say, well, you didn't quite do what the doctor told you to do, and then the satisfaction keeps getting worse and worse as you get all the way down to the millennials have the lowest satisfaction with their physicians. And if I tell you know, somebody in their, if I give choices to somebody that's in their 80s or 90s, they're going to look at me like I don't know what to do. You know, you're the doctor, why would you want choices? And if I see somebody who's 18 and I don't give them all the choices I already researched on the internet, they're going to think that I don't know what the heck I'm talking about, and they're going to go find a different doctor. And so there's a lot of things that are happening, you know, whether you realize it or not. But if you're, you know, if you're sitting there and somebody, you know, if you haven't met this doctor or this nurse practitioner and you don't have a gut feeling that things are going to be okay within the first 20 or 30 seconds, they're probably not going to be okay. And it's okay to try to, you know, find somebody else or, you know, make the most of what you got there. Realize too that we have bad days as well, you know. When I'm seeing you for your cold, I might have just got done telling somebody that they've got cancer. So that can, you know, that can play a role in how it goes too. But the other thing sometimes I'll do in trying to manage the time is break it down to some of the bigger issues. So how doctors think before we even walk in the room, you know, when you call and you say I've got chest pain, that generates a whole list of possibilities, and there's another list of probabilities. So in my mind, what are the 5, 6, 7, 8 things that can cause chest pain? And really there are probably about 50 things that can cause chest pain. And of those, what are most likely to least likely? And then in my mind, there's a third list. What's most likely to kill you? Heart attack. And what's least likely to kill you? You know, I guess shingles, because that's what I've been going with. That happens all the way through the whole process. So when you call, if you call our clinic and you talk to our front desk and you want to see a clinic doc for your chest pain and you threw your shoulder out, you know, putting the boat lift in, you should say, I have a pulled muscle. Because if you tell them chest pain, they're going to assume the worst because they don't, you know, they don't want to, we don't want to miss something either. The two most common things that people see primary care doctors for, in order, one is a cold virus, and 2 is acute back pain. So you know what I can do for your cold virus? Absolutely nothing. I can, you know, really the research, I can tell you to drink honey if you don't have diabetes, because honey actually takes your cough away more than anything else we know of. But otherwise, I just tell you, well, you know, you don't have pneumonia, you don't have that, but you're going to get better, and you're going to get better. And then the number 2, acute back pain, you know, assuming that you can still empty your bladder okay and you can still walk because your legs aren't so weak, 9 times out of 10 it goes away no matter what we do. Whether you see a chiropractor, you see a physical therapist, within 6 weeks, 90% of it is gone. So a whole lot of it is anxiety, or we call it medical literacy, which I've got another slide on that one too. But the idea is it's 3 in the morning, what do I do? You know, I'm scared. I've got a screaming 9-month-old baby and I can't figure out what's going on. you know, it's 3 a.m. I can't wait till 7 o'clock. Our phone line's open at 7 o'clock. So, and almost all of us have same-day spots available. So almost all of us, if you call at 7 o'clock and you have a primary care physician, we're going to work pretty hard to get you in. So what do? You know, it's 3 a.m. and your grandson is at your house and he's 9 months old and he's been crying all night and nobody's gotten a wink of sleep and everybody's stressed out, and it's the first child for your child. And what do? How do you figure out what's going on? On the back of your insurance card, there are resources. So there are 1-800 numbers or 1-866 numbers or whatever the prefix is nowadays. Insurance companies have nurse call lines you can call, and they will give you some advice. Back when I first started, you could call the clinic and you would get eventually, actually fairly quickly, within about 5 or 10 minutes, a doc would be on the phone with you. And I've had several patients say, well, God, why don't you guys do that? That was so nice. I mean, and it was such a, and I agree, it was a great service. I'll tell you, towards the end when we were doing it, we were the last group in all of northern Minnesota to still do that. And we were getting calls. I'd get calls from Ely and Bemidji, and so word got out. And I wear a pager at night, and I think it holds 20 calls, but one night I cleared that pager twice. So I work clinic, I'm on call, everybody that comes in the hospital, I gotta go admit them to the hospital, and my pager's going off, you know, hey, my tooth hurts. Yeah? Okay. And it got to the point where I'd say, boy, you know, we offer this as a service to our patients, you know, which doc do you see? And they'd say, oh no, I don't see you guys, I go to Ely. And I'd say, well, I'd be happy to meet you at my office at 8 in the morning, and I'll take a look at you. No, that's okay, I just... So in any event, you're not going to get a doc, unless you're related to one, you're not going to get a doc on the phone at 3 in the morning. But you can get a nurse on the phone, and that nurse will go through some computer-based algorithms, some problem solving, and guide you and say, boy, this is something that could be something severe, you should go to the emergency room. Or the nurse might say, you know, this is probably something that can wait till, you know, 7 or 8 o'clock. Of course, there's Dr. Google. The computer is a phenomenal resource. And it seems like patients, you know, some come in kind of embarrassed to admit they look things up on the computer. And for me personally, I want to know where you're getting your information from, because I need to know what you're worried about. And sometimes, you know, the things I'm thinking about on the list are different than what you found. And, you know, you might be worried about this thing that happens 1 out of a million times that I've never seen in my career. And I'm over here talking about your shingles rash. And we need to come together, you know, fairly quickly on that. But so familydoctor.org is an outstanding website, definitely on par with, you know, WebMD, Mayo. I remember when I was a kid, my mom had that really thick Mayo book, you know, and every time you get a bloody nose, she's got her nose in the Mayo book. If you still have one of those Mayo books and you want to get rid of it, bring it into me, because I got kind of a small collection, but it's not, don't follow any of the medical advice in there. If it's in a book, it's so outdated that it's not worth reading. And then and MyChart, and I don't know how many people are signed up on MyChart, or if you know what it is, but it's a really good resource when used appropriately. So it's a way to have some access to us, and it goes up through, you know, nurses. It kind of gets filtered, and the important, the high level stuff, you know, if it's something simple, hey, I need a refill on my blood pressure meds, then our nurses can take care of that. But if it's higher level stuff, the message gets through to us, and then you know, we can just basically text you a quick message back. MyChart does not work for, you know, 3, 4, 5 problems. You know, sometimes people send in, it's like 2 pages worth of stuff, and it still can't replace, you know, me sitting down and talking to you and doing a physical exam and whatnot. But I can often say, hey, this is something that can wait for a week or 2 till I'm back from vacation, or I'll get you in today at 2 in the afternoon. So in the Fairview system, we still call it MyChart, but if you're signed up for the old one, that's an Allina MyChart, and you have to sign up for the new Fairview one to get on the Fairview one. They look different, you know, so some of the features that were on the old one aren't on the new one, but some are on the new one that weren't on the old one. But if you had an old account and you've been trying to get it at a, you know, they were supposed to have gotten turned off, but not all of them did. all of the old ones. So if you've been trying to communicate with us with your old MyChart, it's not going anywhere. And then when you come in, every time you come in, we give you that piece of paper, that after visit summary. It's got a sign-on code. So we really are trying to encourage people. We're not like the cities where everybody and their big brother has a cell phone taped to their hip. But this is kind of how you make appointments and all of your lab information. I'll tell you, Mayo's MyChart releases all of the notes. So when you go see a doctor at Mayo, you can see all of your own notes, and you can get all on. And I can see those now. Now that Mayo's on our computer system too, I can see them directly from our computer system. Mayo last month, I believe, switched to the Epic system. And we had a tough time with our Epic rollout, but Mayo had a tough time with their Epic rollout. We are hooked up with the St. Mary's, because they're on the Epic computer system, but not St. Luke's. They are not on the Epic system. But we're a Fairview clinic, so any Fairview, Hibbing, Princeton, anything at the university, all of that is all directly in our chart. And then when we're going to the other sites, we're leaving our Fairview chart and looking at their information, but it's still in the Epic system. We also have a clinic here in the Y building. That is a combination of a walk-in, that's kind of an old-fashioned style. It's a combination walk-in clinic and scheduled visits. So the visits are scheduled a little bit farther apart to make room for people to just walk in the front door. And they take anybody that walks in. So unlike the rapid clinic where we kind of say, well, maybe if it's more complex, you should go to the regular clinic. This is a regular clinic that accommodates walk-ins. 5 days a week, closed over the lunch hour, but what is it, 8 to 5 hours, I believe? 8 to 4:30, closed from 12 to 1. It's a really neat partnership that we have here with the Y. The phone line's open at 7. I personally and almost all of our docs try to maintain certain same-day opening spots, and because there's a shortage of us, we want those filled. Those do tend to fill up, usually between 7 and 8. Most of those fill up. We can usually accommodate you if you just show up, but there are some scenarios where either you would wait extra time or you might get shunted over to the rapid clinic or maybe to the emergency room. The converse happens too, where sometimes if the rapid clinic has 8, 10 people sitting in the waiting room, they might ask me if I could see one of these kids with a strep throat or something, and we might move you over to the regular clinic. But it's usually best to call first. I know it wasn't quite a list of go to the ER for this or go to the, but hopefully you got some better ideas on where the best place is to go.